Thank you. Good evening, doctors. We welcome you to this experience sharing program on managing PPH, case studies from labor room. It's brought to you by Hetero Healthcare. Hetero Healthcare, we have, just to give a snapshot of Hetero Healthcare, we have 25 years of excellence with 36 state-of-art manufacturing facility. We have 300 plus products in portfolio and presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. Hetero Healthcare is 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation. We have distinction of bringing to market biosimilar products within 5 years of initiation. Today's program, experience sharing program on managing PPH, we have got honorable speaker Dr. Prasun Kar with us. Dr. Prasun Kar, welcome to this program.
Good evening.
Sir is MBBS MD Gynecology and Obstetrics, consultant gynecology and obstetrics in Mednipur from Calcutta National Medical College and Gratal Super Specialty Hospital, Mednipur. Welcome, sir, and over to you the session. I will run the slides, sir.
Thank you, Doctor. I am starting my speech today. Please make it bigger for me. Please make the slide bigger for me. It is small one. Can you make it full screen? Hello?
Full screen, sir. The
I'm
slide
not
share,
getting
sir.
a slide to see.
I'm on slide share mode.
Yeah, I'm getting it.
Yeah.
But the screen is not visible to me.
Vivas,
Sir.
sir is unable to see the screen. You can see the screen, Vivas?
Yes, I can see the screen, but if you can do full screen for this slide.
This is
Yeah,
full
yeah.
screen. This is full screen.
This is
I
full
think 1
screen,
minute,
but
sir.
I get it fit to Windows. Okay.
This is full screen.
If you can, sir, click on those 3 dots on more
Mhm.
And
see.
Now I'm getting 100% zoom, but it is not fitting to the window.
yes, because what I should do, I'm on the 3 dots.
Yeah, 1 minute. And the more,
Yeah.
you will see a full screen.
What I'm saying, I'll tell you. I'm saying disable annotation for others, hide name of annoters, hide video panel, hide floating meeting records, share computer sound, optimize for video sharing.
Yeah, Nagadevi, can you help us, please?
What happened, sir?
We need a full screen of this, this.
I will share again.
Yeah, please share again and make it full screen, sir. Right.
See, now I will again share and it make it a full screen.
See, double click to enter full screen mode, sir. You need to double click.
Yeah.
You double click on this slide, sir.
Double tap on screen, sir, once.
I'm double tapping. But I'm going into the slideshow mode.
Click the minimize button, sir. No. Hello? Sir, click the minimize button, sir. You're closing the tab.
Yeah, I'll get it now. Which one minimize?
The sign in.
Sign in.
Yeah,
Zoom.
sign in. The into button is there now, sir.
But I've been always doing this, I've been doing it in the slideshow mode. Anyway, I'll make this slideshow mode big. Let's see if you can see this.
No,
is
that
it fine now?
That will not
sir.
work, sir.
The screen was more.
Yeah, you will have to.
Then what do I do?
Sir, go to the presentation mode.
Yeah.
Click one each slide and double tap. Try this one, sir. Yeah, is it okay, right?
This is big enough.
So is it visible to you, sir, Dr. Prashant, sir?
No, I am not getting the slides properly. It is bigger. Okay. It is not fitting the screen.
You're saying so it is bigger than the screen. It is
Bigger than the
going.
screen.
Sir, then you minimized your screen, sir, once.
My screen.
Yeah.
My screen is.
Now my mode is fit to screen.
My mode
Mhm.
also visible, sir.
You
It
can
was
see
good.
now Nagadev, you can see
Yeah,
clearly. No?
yes, sir.
We
It
can
was
see, sir.
visible.
Actually. Yeah.
Sir, click control minus.
Me?
Control and minus.
Yep.
Hmm. Hmm.
Is it okay, sir?
Let's check. Not yet.
Because you can see my slides.
Yes, I can see your slides. Sir.
You can see.
Now, yeah.
Yeah, Nagadev
I
you can
think
also
it
see.
has to be made.
Yeah, I'm also visible your screen, sir.
Yeah.
I'm not getting. Okay, okay, okay.
Yeah.
Right, sir. Yeah.
Yes. One slide is over there. Should I start?
Yeah, yeah.
Or
You
ah,
can start.
yeah. Overview of the postpartum hemorrhage. Next slide, please. Now, postpartum hemorrhage a daunting event. PPH is loss of at least 500 ml blood following vaginal delivery and 1000 ml following cesarean section. Now, PPH is common and can occur even in women who are not at risk. PPH is the leading cause of the maternal mortality in low income countries and the primary cause of the nearly one quarter of all maternal deaths globally. Next slide. Now, postpartum hemorrhage. It's unfortunate yet common. Now, it is the leading cause of maternal mortality, acco- accounting for about 35% of all maternal deaths. Now, MMR in developing countries was 240 per 1 lakh live births compared to 16 in developed countries. Now, global PPH incidence. 14 million women suffer from PPH. Incidence of PPH is reported as 2 to 4% after vaginal delivery and 6% after cesarean section. Now, PPH incidence in India. More or less 38% of maternal deaths are due to PPH. 25.7% of global deaths takes place in India, and two-thirds of these deaths attribute to PPH. In India has an unexpectedly high maternal death rate of 540 per 1 lakh live births. Next. Now, etiology of the postpartum hemorrhage. Number one, there is tone, uterine atony, inability of the uterus to contract, which may lead to continuous bleeding. Next is thrombin, that is the coagulopathies, failure in clotting. Next is trauma, uterine trauma, injury to birth canal, rupture of uterine inversion or lacerations, tissues, retention of placenta and clots, and abnormal placenta. Now, clinical findings in PPH. Usually, we all know there is abdominal tenderness, circulatory collapse, increasing abdominal girth, loss of uterine contractions, maternal tachycardia, and vaginal bleeding. Now, in the table, we can show the clinical findings in PPH. In case of mild PPH, there is 500 to 1000 ml blood loss, that is 10 to 15%. And in case of mild PPH, there is 1000 to 1500 ml blood loss, that is around 15 to 25% loss. And in moderate PPH, there is 1500 to 2000 ml blood loss. And in severe cases, 2000 to 3000 ml blood loss, that is around 35 to 45%. Now, blood pressure changes. In case of compensation PPs, there is no blood pressure change. But in case of mild PPs, there is slight fall, that is around 80 to 100 millimeter of Hg. In moderate PPs, there is market fall, that is around 70 to 80 millimeter of Hg. And in severe cases, there is profound fall of blood pressure amounting to 50 to 70 millimeter of Hg. Now, symptoms and sign. In case of compensatory PPS, there is palpitations, dizziness, and tachycardia. In case of mild PPS, there is weakness, sweating, tachycardia. And in case of moderate, there is restlessness, pallor, and oliguria. And in case of severe PPS, there may be collapse, air hunger, and oliguria. Next slide, please. Now, diagnosing postpartum hemorrhage. Initial evaluation. Now, rapid assessment of the patient's status, presence of tachycardia and hypertension, and assessment of the vital signs and the blood loss. Now, examination at the time of the hemorrhage. Assessment of the entire genital tract for laceration, hemorrhage, or signs of uterine rupture. Manual examination for retained placental tissue. Assessment with the bedside ultrasound to check if their uterus is non-contracted, and evaluation of the uterus to check for uterine inversions, and laboratory assessment, complete blood counts to check hemogram, hematocrit, and platelets, coagulation studies, and assessment of fibrinogen. Next, please. Now, approach towards the postpartum hemorrhage. Clinical approach. Poor uterine tone. Clinical finding abdominal palpation. There may be uterus feels relaxed, boggy, and soft. Now, uterine fundus may be felt above the umbilicus if uterine cavity is filled with blood and clots. Investigations usually full blood counts, coagulopathy profile, and urea and electrolytes. If the patient is not responding to fluid and blood replacement, then abdominal ultrasound can be done to exclude uterine rupture and intraperitoneal bleeding. Now, management. Now, uterotonic agents are usually used. We use oxytocins, prostaglandin, and argon alkaloids. Now, hemolysis algorithm. There are only surgical management when we fail to manage the bleeding by medical management. Now, if there is tear or trauma, clinical finding, there will be bleeding from the areas of trauma and within the perineal tract. Now, uterine rupture or extension of the uterine angles in case of cesarean sections, tears during the cesarean sections, and extragenital causes are also there, such as the subcapsular liver rupture or rupture of the ovarian or splenic vessels. Now, retained tissues, clinical findings. Retained placenta or membranes may also cause the PPH, identified during the bimanual examination. Investigations are under anesthesia. That is, if there is no trauma noted during the routine bimanual examination, we can go for examination under anesthesia. Management usually removal of the placenta or retained products of the conception under regional or general anesthesia. Now, if there is coagulopathy, clinical finding, continued bleeding in contracted uterus. Investigation, urea and electrolytes are usually done, full blood counts and coagulation profile. Management, it is basically medical management, immediate replacement of blood and coagulation factor and platelets. Surgeries, only with the trauma or other atonic hemorrhagic non-responding cases, then we can go for surgical management. Next, please. Now, rationally for development of carbetocin in the new heat stable formulation. Now, carbetocin is available in a room temperature stable formulation and convenient vial presentation. Now, some advantages of carbetocin over the oxytocin. Carbetocin is stable at room temperature, has shelf life of 24 months at 30 degrees centigrade and 75% humidity, avoids need for cold shell storage and logistics, and is provided in a vial. Next, please. Now, use of the uterotoric agents. Now, what uterotoric agents we use? We use usually oxytocin, carbetocin, argometrin, syntrometrin, and misoprostol. Now, what is the time of administration? At the crowning of the baby's head, at the delivery of the anterior shoulder, at the end of the second stage of labor, and following the delivery of the placenta. Prophylactic use, prevention of PPH, active management of the third stage of labor, and therapeutic use, the management of the PPH. Next, please. Now, carbetocin is a next generation drug for PPH management. The drug is the synthetic long-acting analog of oxytocin. Therapeutic indication is the prevention of postpartum hemorrhage due to the uterine atony. And posology and administration, one vial contains 100 microgram of carbetocin in 1 ml solution for injection. It has prolonged shelf life, prolonged half-life and reduces enzymatic degradation. Next, please. Now, carbetocin, the clinical evaluation. Carbetocin is non-inferior to the oxytocin according to WHO Champions trial. Champions trial, that is the carbetocin hemorrhagic prevention, the larger clinical trial in the prevention of PPH. Study design non-inferior double-blind randomized trial. That is the objective is to compare the effectiveness and safety of the investigational heat level carbetocin to oxytocin in the prevention of PPH after vaginal birth. The trial conducted by the WHO Department of the Reproductive Health and the Research. Now, patients enrolled around 30,000 women across 10 countries, including India. Primary outcome, the proportion of the women with the blood loss of at least 500 ml or in the use of the additional irritating agents. The proportion of women with blood loss of at least 1000 ml. Next, please. Now, there are some comparative parameters when you use carbetocin and oxytocin. In almost all cases, parameters are same. Blood loss of more than 500 ml of use of additional eutotonic, same, more or less same in case of oxytocin and carbetocin. Blood loss greater than 1000 ml, that is also same in both cases. And at least one unanticipated AE, that is the 4.5%, 9% in case of carbetocin and 4.7% in case of oxytocin. The frequency of blood loss of at least 500 ml of use of the additional irrotonic agents with carbetocins was proven to be no inferior to carbetocin. The use of additional irrotonic agents interventions to stop bleeding and adverse effects did not differ significantly between the two groups. Conclusion, carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of the additional irrotonic agents. Next page. Now Cochrane review. Carbetocin for prevention of postpartum hemorrhage. In this Cochrane review, data from 11 studies involving 2,635 women were included. The author concluded that for women who undergo a cesarean section, carbetocin resulted in statistically significant reduction in the need for therapeutic intertonic compared to the oxytocin. Also, carbetocin is associated with less blood loss compared to symptometrin in the prevention of PPH for women who have vaginal deliveries and is associated with significant fewer adverse effects. Next, please. Now, guideline recommendations. Now, guidelines recognize the benefits of carbetocin for prevention of the uterine atony. Almost all societies recommend it. WHO recommends only one of the following oxytocins, that is the carbetocin should be used. SOGC Canada recommends carbetocin. FIGO recommends carbetocin. And other societies also recommend carbetocin for prevention of PPH. Next, my experience with the carbetocin. The smarter superior. Now, case 1. A patient, 24-year-old female, gravida 1, para 1, that is the primary gravida. No, this is gravida 1, para 0, I think. Delivery, emergency cesarean section, that is a C-section at term. Complication, massive postpartum hemorrhage. Clinical presentation, excessive vaginal bleeding, post-cesarean section, more than 1000 ml. Hypotension, and there was tachycardia. Definition of incidence of PPH. Definition of PPH is blood loss more than 500 ml vaginal delivery or more than 1000 ml in cesarean delivery. Incidence 1 to 5% of deliveries, leading cause of the maternal morbidity and mortality worldwide. Now, risk factor of PPH. Risk factors mainly cesarean delivery. uterine atony, multiple gestations, prolonged labor, and previous PPH. Pathophysiology of PPH, uterine atony. Most common cause of PPH, that is the failure of the uterus to contract post-delivery. Now, consequences, severe bleeding, hypovolemic shock, multi-organ failure, and untreated if untreated. Now, clinical presentation and diagnosis. Symptoms, excessive vaginal bleeding, hypotension, tachycardia, severe pallor. Diagnosis, clinical assessment of blood loss, initial and vitals monitoring, and lab test, that is hemoglobin and coagulation profiles. Now, management of PPH. Initial steps, uterotonic agents, that is oxytocin or carbetocin, whichever is available. Bimanual uterine compression, fluids and resuscitation and blood transfusion. Second line, tranexamic acid, uterine balloon tamponade, surgical interventions. Now come to the role of the carbetocin. Carbetocin, which is the long-acting oxytocin analog, it has advantages of prolonged uterine contraction and effects on versus oxytocin. Single dose administration, that is the IV or IM, can be given and effective in prevention and treating uterine atony. Dose is 100 microgram IV or IM, that is one vial. The case management. Interventions, carbetocin 100 microgram IV given post cesarean sections. Response, reduced bleeding, improved uterine tone observed. Additional measures, fluid resuscitation and monitoring of vitals. Outcome and follow-up. Outcome, patient stabilized with carbetocin and supportive care. Follow-up, monitoring for anemia and counseling future pregnancies. Conclusion. Key point, carbetocin is effective in management of PPH, especially post-cesarean section. Importance, prompt recognition and management of PPH, crucial for maternal safety. Guidelines, WHO, ACAG recommends on PPH management. Now, comparative efficacy of carbetocin, oxytocin in PPH prevention and treatment. A patient, in case 2, a patient with 30 years old multigravida, that is D3P2, with previous 2 normal vaginal deliveries, current pregnancy, term pregnancy at 39 weeks of gestation, goes into spontaneous labor, delivery, normal vaginal delivery with episiotomy. Now, outcome, healthy baby boy of 2.2 kg delivered. Now, postpartum hemorrhage, that is we know the definition and we know the risk factors. PPH occurred in this particular case. Next slide, please. Next slide, please. Now, comparison with the other uterotonics, agent, route, duration, and common use. Oxytocin IV infusion, short, first line PPH prophylaxis. Carbetocin IV or IM, long effective alternative for the PPH prevention. Misoprostol, oral or rectal, variable PPH treatment and prophylaxis in resource limited settings. Now, administration and effects. Administration given IM or IM post placental delivery. Effect, prompts sustained uterine contraction, reduces bleeding. Monitoring uterine tone, bleeding, vital signs post administration. Now, case management. Carbetocin administration 100 microgram IV given post placenta delivery. Observation, good uterine tone, minimal postpartum bleeding. And additional case, episiotomy repair and monitoring for PPH sign noted. Now, advantage of carbetocin. Advantage is this is a single dose, convenient administration versus oxytocin infusion. Efficacy, non-inferior to oxytocin in prevention of PPH in some studies. Safety, generally well tolerated. However, there are some side effects. Now, PPH prevention strategies. Active management of third stage labor, uterotonic administration, either carbetocin or oxytocin, controlled contraction and uterine massage. Risk assessment, identify patients needing additional vigilance. Now, patient outcome. Uneventful postpartum period, no PPH, healthy newborn with the good Apgar scores. Conclusion, the effective option for PPH prevention in normal deliveries. Now, importance, prophylactic uterotonics, key in the reducing PPH related morbidity. They are all recommended WHO guideline. Next, please. Panel questions. The Carbiact, the brand name is Carbiact, and it is carbetocin injection 100 micron per ml.
Some of these questions, sir. What is the patient profile where doctors can anticipate a PPH? Which patients are likely to get?
In most cases, the elective cesarean section in case of post-cesarean mother, polyhydramnios, multiple fetal gestation, and prolonged labor. These are the cases which may go into PPH.
So fibroids, uterine fibroids, and diabetic
Associated
patients.
uterine fibroid
Yes.
may occur, but we get it only in case of elderly mother.
Elderly mothers. And with IVF increasing, I think there will be many mothers who will be little
Yeah,
elderly.
correct. Mhm.
Can we use carbetocin in case of retained placenta? Any experience, sir?
Yeah, I have used many times. Initially, we have to do the MRP, that is manual
MRP.
removal
Correct,
of
correct,
placenta.
correct, correct, correct.
After that, when the uterus is moderately contracted or in the process of contraction, we have to give that carbidocin injection.
Any incidence of secondary PPH you have seen with carbetocin?
It happens sometimes.
Sometimes it happens.
Initially, we give carbidocin, but sometimes later, again, there is PPH, and we have to manage with the additional oxytocin.
Uterine. Can you use carbetocin in case of RH negative mothers?
Yeah, we can use.
Anyways, we are treating with that anti-D, etc., etc. So,
Yeah.
if a doctor uses carbetocin for prevention, can he use? I mean, if he uses oxytocin for labor induction, can he use carbetocin for prevention?
Now, oxytocin we use for labor induction, we
Induction,
use oxytocin. But
oxytocin.
in case of induction, we do not use carbetocin.
We do not use carbetocin.
It is used only for the prevention of PPH.
Okay. Yes, in fact, carbetocin is recommended only for prevention of PPH, not even for treatment or not even during induction.
No, not for induction of labor.
Yes.
Mm.
Which is the route you generally prefer, sir? How long you have been using carbetocin?
I am using it for more than 1 year.
1 year. And which is the route
Uh,
you prefer?
I usually give it IV route.
IV route.
Usually, but there is some sort of chest pain, nausea,
Okay.
vomiting. It occurs after IV route.
IV route. And IM route, relatively less side effects.
Relatively less.
Less. But which cases you prefer IV over IM?
In case of elective serums, I prefer IV.
IV. Or in case of normal deliveries, IM route should be sufficient.
Yeah, I am.
And you have just mentioned adverse effect profile. But are those adverse effects severe enough or they are mild and self-limiting?
Mild and self usually
Self-limiting.
it subsides within 10 to 15
10 to
minutes.
15 minutes, correct. So you don't need any intervention.
Usually not needed, and
No.
usually at the time when the surgeon is busy with that CN section, usually anesthetist take over.
Anesthetic.
Anesthetist, and there is a role of anesthetist obviously in this
Correct,
case.
correct. And sir, if there have been many cases where the patient has not responded with carbetocin, it's quite likely. Then which other additional uterotonics you prefer in your order of preference?
Alternative, we usually is the traditional syntocinon, oxytocin, and in rare cases we
Ergometrin.
have to give argometrin, that is the
Ergometrin.
methergine, which was widely available few years ago, and we can go for bisoprostol,
Misoprostol.
parectal or sublingual.
Yeah. Of course, one has to be careful about the bronchial asthma and other side
Obviously.
effects. Yes.
Mhm.
You just mentioned carbetocin. I suppose the major advantage is a single use and doesn't require hospital. I mean, it doesn't require cold chain, and which
That
is
is the main
yes.
advantage. It doesn't
And
require any
in our interiors, all these things will matter, sir. Even in
yeah.
Mumbai, we have got a lot of power outage many
Mm,
times.
mm.
Yeah, and so in the interior, sometimes it is difficult to get help also. So single injection, which can be given IV, IM, I think.
It can be readily available in the
Ah,
very rural areas or remote
correct.
areas.
That will be a practical advantages more than the
More advantage, what I
yes.
suppose that it acts rapidly and
Ah,
we are relieved of any PPH.
absolutely. PPH, sir, is one condition where PPH is one condition where we like to discuss. We don't want any patients. Should carbetocin be kept as reserve drug or should be first line?
Till now, I think it should be kept as a reserve drug because
Reserve
of
drug.
its cost.
Cost, okay. And you just said the role of anesthetist vis-a-vis gynecology. Is the anesthetist suggest you sometimes, or you suggest tell anesthetist which drug to use?
Actually, I suggest, but we the gynecologist suggest, and the anesthetist follow. In
Follow.
our hospital, we routinely use carbetocin
Oh.
in elective CN section or in
Correct.
all CN section.
Yeah, the hospital must be a big setup, na, where the anesthetist will be available and yeah. Okay. So to conclude, what is your take-home message for the audience? Your opinion, your experience, which matters most to all of us.
Everybody should be familiar with the use of the carbetocin injection, be it IM or IV. If the IV is given, some sort of uneasiness occurs in the patient. In IV route, usually we prefer in CN section, but in case of vaginal delivery, carbetocin may be used in anticipation of PPH. It can be safely used by IM route, and it's a wonder drug, I think.
Right, sir. In fact, that was a lovely experience sharing. Because what happens is that there are many literatures and there are many references, but our own doctor's experience always matters the most. Your hands-on experience, it gives the confidence to the other participating doctors. So thank you very much for that, and thank you very much for taking time to, address the doctors. Thank all the doctors who took time and attended this. And thanks marketing team, sales team of Hitro for coordination, and IT team for super support and backup. Thanks all of you. Sir, you can sign off. I wish you a very pleasant
Thank you all.
weekend.
Thank you.
Thank you. You can sign off, sir.
Okay.
Thank you, sir. Thank you so much for accepting our invitation, sir.
Thank you.
Thank you so much, sir.
We can leave, no? Nagadevi, we can leave, no?
Thank you,
sir.
Nagadevi. Thank you, Dr. Prashant.
Okay,
Bye-bye.
thank you.